With that, I'm very pleased to introduce our first speaker for today, Professor Roland Diel, who is full professor at the University Medical Center Schleswig-Holstein in Kiel, Germany, where he's also a part of the Institute for Epidemiology and Center of Airway Research.
Ladies and gentlemen, I've been asked today to address a topic considering prevalence in evaluating results of laboratory testing for SARS coronavirus 2 infection. Before going into detail, let me introduce two parameters which address specific properties of any diagnostic test, irrespective of the type of infection that is to be detected or excluded: sensitivity and specificity. Sensitivity of a diagnostic test is a rate of concordant positive test results relative to a reference method, the so-called gold standard. And specificity of a diagnostic test is a rate of concordant negative test results relative to a reference method. In our example, a diagnostic test shows 233 positive and 824 negative results, but in fact, there are 235 persons with the infection and 812 persons who are not infected. Accordingly, sensitivity of that test is 94.3%, and specificity, calculated by dividing the number of test negatives by the total of all 812 persons without the infection, is 99.8%. Reference methods, however, can have different qualities that may influence results of comparison studies. As an example, molecular technology is considered as gold standard for detection or exclusion of SARS coronavirus 2 and used as reference method for evaluating the performance of other new diagnostic tests. But what happens if the sensitivity of the gold standard is lower than 100%? In other words, if the sensitivity of the reference test is clearly lower than 100%, as is the case with the PCR test in our example, and if there is discordance between the positive results in the reference test and those of another diagnostic test, the question arises: how many of the two results scored positive in the new test but negative in the reference test are really false positive in the new test? The same question arises with respect to discordant negative test results if the reference PCR test in the next example has maximal sensitivity but a low specificity. How many of these 14 discordant results are false negative in the new diagnostic test? Do these negative test results indicate a low sensitivity of the new diagnostic test, or is the discordance simply the result of the low specificity of the reference test, which is known to produce false positive test results? The problem we have to face is that in the individual diagnostic situation, physicians usually have only one diagnostic result provided by a lab using one particular diagnostic test. Therefore, the physician has to trust that the positive or negative diagnostic results provided by the lab are highly accurate. Sensitivity and specificity as test-specific properties alone are not sufficient in test interpretation because these parameters are fixed values that do not consider the prevalence of the infection of interest in the investigated collective. The interpretation of whether a positive or a negative test result correctly represents an infection or the absence of infection depends on two parameters: the positive and the negative predictive value in the given situation. Both conditions depend on sensitivity and specificity as specific properties of a test, and very importantly, on the proportion of infected persons in the tested population, called prevalence. The positive predictive value is calculated as follows: sensitivity times prevalence divided by sensitivity times prevalence plus, in brackets, 1 minus specificity times, in brackets, 1 minus prevalence. In contrast, the negative predictive value is calculated as follows: specificity times, in brackets, 1 minus prevalence divided by, in brackets, 1 minus sensitivity times prevalence plus specificity times, in brackets, 1 minus prevalence. In other words, The positive predictive value is the number of true positives divided by the number of true and false positives. And the negative predictive value is the number of true negatives divided by the number of true and false negatives. In order to illustrate these relationships, let's have a look at the example in the next slide. As you can see here, the infection of interest is present in 247 of the 1,058 persons tested, equivalent to a prevalence of a bit more than 23%. The diagnostic test in our example detects the infection in 233 of the 247 infected persons and assigns 2 persons as infected who, in fact, have no infections. Accordingly, the positive predictive value of the test is 99.15% and the negative predictive value is 98.30%. To say in other words, a negative test result of the diagnostic test would exclude the infection with a probability of 98.3%, and a positive test result of the diagnostic test would include the infection with a probability of 99.15%. Let's now come to the first question. With respect to the test, why is it important that we take the prevalence of SARS coronavirus 2 infection into consideration? The answer is quite simple. The prevalence of SARS coronavirus 2 determines the prognostic value of an individual test result in conjunction with sensitivity and specificity. Under which circumstances can the positive predictive value or the negative predictive value of a coronavirus 2 test be expected to be low? As derived from the formula, the positive predictive value of a test is low if the denominator of the respective equation is low, especially if there is both a low prevalence of the infection in the investigated population and a low specificity of your test. On the other hand, the negative predictive value of a coronavirus test is low if there is a high prevalence and a low sensitivity of the test. Let's now take a deeper look at the actual prevalence of SARS coronavirus 2 infection in the German population. According to a recent report of the Robert Koch Institute, the German Public Health Institute, an infection prevalence varying between 0.61% and 9.3% was found with a mean value of 2.9%. And in Europe, the prevalence of the disease following SARS coronavirus 2 infection can be even much lower, with the prevalence between 0.024% in Latvia and 0.152% in Spain. Thus, we are aware that the prevalence of SARS coronavirus 2 as reflected in lab results for investigated specimens and in the number of diseased patients is fairly low in Germany and other European countries. In this situation, a highly specific diagnostic test is preferred in order to achieve a high positive predictive value for ruling in SARS coronavirus 2 infection. So let's pretend that 500,000 specimens from persons suspected of SARS coronavirus 2 infection were collected in Germany. In a low prevalence scenario, the actual prevalence of SARS coronavirus 2 infection is only about 0.6%. In a high prevalence scenario, it is 9%, given the variability in the range of reported infections in Germany. Let's further assume that these specimens are tested with a PCR method whose sensitivity and specificity are both 99.5%. Despite the very high specificity of the test itself, when the prevalence in the tested population is only 0.6%, the positive predictive value of this test is surprisingly low at about 55%. The negative predictive value, however, is nearly 100%. This is due to the very low infection prevalence in the population combined with the very high sensitivity of the PCR test. In contrast, when given a prevalence of 9% in our second scenario, the positive predictive value of the test increases dramatically to more than 95%. Meanwhile, the negative predictive value remains nearly unchanged at more than 99%. Here you can see a graph showing when positive and negative predictive values are plotted against true prevalences of SARS coronavirus 2, where the blue line represents the negative predictive value and the orange line represents the positive predictive value. As you see, the negative predictive value curve hardly changes at all over a broad range of realistic prevalences, and only begins to decrease when the prevalence surpasses a threshold of about 70%. The positive predictive value, however, only achieves a moderate level, 85.6%, at the average SARS coronavirus 2 prevalence reported for Germany, 2.9%. And perhaps most notably, the positive predictive value exhibits substantial variability all within the prevalence range between the worst case scenario and the best case scenario. The positive predictive value only achieves the desired value of 95% until the true prevalence of SARS coronavirus 2 reaches approximately 9%. In light of the low absolute prevalence of SARS coronavirus 2 in most countries, a public discussion, which has begun months ago, has focused on the importance of test specificity in interpreting positive test results. If a positive predictive value of at least 95% and a negative predictive value of at least 99% was considered adequate, this exemplary PCR would need a prevalence of 9% and more in the investigated population to achieve a positive predictive value of at least 95%, and would exclude a SARS coronavirus 2 infection with a probability of at least 99% up to a prevalence of 65%. Prevalence rates below 9% indicate the critical range in which application of a proper rule-in is not possible. In this example, given a PCR testing system which exhibits sensitivity and specificity both at 99.5%, we can currently generate positive and negative predictive values of at least 95% only when SARS coronavirus prevalences lie between 9 and 65%. The prevalence range where a PCR, given both sensitivity and specificity of 99.5%, would generate positive and negative predictive values of at least 95% at the same time, goes from 9 to 65%. Inconvenient, but a mathematical fact. In contrast to the molecular test, let's now have a look at the antigen test. In our example, we use the Sophia SARS antigen FIA test, which has a lower sensitivity of 96.7%, but a maximal specificity of 100%. Again, we are testing populations in which the prevalence of SARS coronavirus 2 infection is either 0.6% or 9%. Although the specificity of this test is only slightly higher than that of the PCR in our previous example, the positive predictive value drastically increases even when the prevalence is only as low as 0.6%, achieving values of nearly 99 or 100% respectively. The negative predictive value in this example would only decrease significantly when the prevalence is higher than 25%, a situation which appears to be quite unrealistic if the test is applied to mass testing. Here, the range for proper ruling in and ruling out includes infection prevalences between 0.2 and 25%. When comparing the test-specific properties of both tests, the consequences are obvious. When the expected prevalence of SARS-2 coronavirus is under 25%, the antigen test should be the preferred testing method, whereas in subgroups where a prevalence of more than 25% is realized, for example in close contacts, the PCR method should be chosen. A retesting of negative results of antigen tests cannot be recommended and is only required in high prevalence situations. Well, what happens when negative results of the Sophia are retested by PCR in a low prevalence mass testing? When assuming a prevalence of 2% coronavirus 2 infection in 500,000 tested persons, the antigen test would produce only 330 false negative results and 40 false positives. In other words, only 330 persons with the infection would be overlooked out of the total of 10,000 true infections. Thus, the prevalence among the persons testing negative on the antigen test would only be 0.067%. In comparison, retesting with PCR would produce 2,450 false positive results, a magnitude which can hardly be considered acceptable. From an economic point of view, the consequences of these scenarios just mentioned would be dramatic. 990,281 tests would need to be conducted on PCR just to detect the 330 overlooked additional infections instead of 500,000 tests. And furthermore, 2,450 out of the 2,678 total positive tests would be false positive, whereas only 228 test results would be correctly positive. This retesting leads to a starkly low predictive value of positive results of just 8.5%. And in fact, in cases where the specificity of the antigen test is higher than that of the PCR, we may actually consider thinking about retesting of PCR test positives with an antigen test. Taking again the test-specific properties of both the PCR and the antigen test from our prior examples, retesting of positive PCR results by the antigen test in a low prevalence situation of 2% would in fact reduce the number of 2,450 false positive results to nearly zero. The price paid in retesting using an antigen test is that 329 SARS coronavirus 2 infected persons will be missed. In my personal view, it perhaps becomes a political decision of what ultimately is considered appropriate. Do you send 2,449 people who falsely tested positive for SARS coronavirus 2 into quarantine? Or do you miss 329 people who do have the infection and could then transmit the virus to others? So this concludes the bulk of my presentation. Let's now review a couple of take-home messages I have for you. PCR tests have a high sensitivity for the detection of SARS coronavirus 2 and provide a high negative predictive value over a broad prevalence range. Nevertheless, in low prevalence situations, specificity matters, and false positive reactions with any diagnostic method can strongly reduce the positive predictive value, leading to misclassifications. Therefore, a diagnostic test like the SOPHIA SARS antigen FIA with a slightly lower sensitivity but higher specificity than a PCR test can be the more effective testing approach in low prevalence settings by providing a nearly equivalent negative predictive value, but a much higher positive predictive value. Depending on the assays available in a specific setting, the combination of an assay with higher sensitivity and an assay with higher specificity can be the best solution. Retesting of all antigen test negative specimens by a PCR test cannot generally be recommended in low prevalence settings if the utilized PCR does not provide a specificity of nearly 100%. Retesting of PCR positive specimens by a test with a higher specificity than that of the PCR would make sense in a low prevalence setting in order to avoid misclassifications, especially when other respiratory viruses become increasingly present in the upcoming winter season. Thanks for your attention.